surgeon at our Apex Hospital in Banjul. Dr. Jallo, if you can just take us through something. And we know the pediatric unit in Banjul is doing a brilliant job, managing all sorts of things, that are referred to them, but the concern is sometimes when we have to race against time, you have to carry patients from very far away places, racing all the way to Banjul with all sorts of transportation complications. Do you think this sort of infrastructure could be doubled, or this sort of efforts could be doubled in the hinterlands of the country? By that I mean the rural area.
Thank you so much for having me, and thank you so much for team as CPS for organizing this forum. And also I'll add my voice on apologizing for the state of the program. And see, we are all guilty because we all have schedules after this program. So that's it. And I'm also happy we have students here in our midst. I hope you are doing encouraged with these activities. Now, coming to your questions, the status for the health sector is in three types. You have primary health care, and then you see Dr. Hadiba really dilated on the primary health care, and then secondary major health centers, and then also some other hospitals. Then you have the cashier. So in the cashier, we all know by the time we receive our patients, they come very late with different complications. There was not a time when we receive a patient where very early, some diagnosis as common as what we call osteopenia, a mass in the groin. Some as common as what we call appendix. Some as common as intussusception. But in fact, since we came in the hospital, when I look at the patients, the one that is early in that category, not less than, not more than 4 days. Not more than 4 days. So then you realize that we in the teaching hospital, it's to our interest that we have the primary health care, then the secondary strengthened, so that we'll have good outcome. Because the nature of that's the way the patient presents to you determines your outcome. So I think going forward, we need a robust referral system from the primary, secondary, tertiary. A lot of work has been done. Ambulances are there, but then the big question is, our ambulances well equipped to handle, for example, a neonate delivered in the village? Our ambulances do they have the capability to bring this baby for us with less complications, where resuscitations will take place in the ambulance while the patient is referred to us? And then also another thing that is of interest for me is the anomaly scan that it's done. Most of the patients we receive, especially the neonates, they are received, the diagnosis are made post in the neonatal period, and then this clearly affects outcome. So there are a lot of work. Lot of work is really needed to be done to change those narratives.
And we all know what it takes to have a very good outcome in the tertiary institution. And then it's just doing some little adjustments, But I must say, a lot of improvements have taken place over time.
Thank you very much, Dr. Jallo. Would you say those adjustments are little? Because really, we've got one Apex hospital with one pediatric surgeon at the moment. Would you say it would really help if we have in the planning? This is not something that is for today, but would you say it will help if we have in the planning to have another similar hospital elsewhere in the rural area, maybe somewhere in Yamanari or somewhere in Madina Angale, to just have a big hospital that's going to be very equipped and have the right personnel, sort of double the efforts that are being done at Edward Francis.
That would be very wonderful. But looking at what we have now, the pace we are moving, if we want to start thinking along that line, I'm sorry, it may distract us. For example, now, to run a proper surgical tertiary institution, you need capacity in terms of that human capacity. We don't have it. And then, for example, it's really not something to go home with to say, I am the only. It should not happen. And then that's the scenario we are having. One neurosurgeon, maybe orthopedics have tripled themselves. Then apart from the human capacity, then you have the nursing capacity. Then aside that, then you have the material capacity. We are still struggling in the teaching hospital. Now the word catch-up is something that people don't like using. You join people where they are, you bring everything, and then you join where the developed world or the people who are ahead have reached. So, but looking at our stage, we are very, very, very much behind. So now thinking of having another tertiary institution would really be far-fetched, and it would create a lot of distractions.
Sometimes they say never say never.
Yes, it's something that could be in the pipeline.
Thank you for that. Let's move on to the next questions as far as pediatrics is concerned. So we all know the importance of immunization, and certainly we know that it's key in preventing most pediatric infections. So as a nation, what are we or should we be doing to educate parents about the importance of childhood vaccination? As recent as last year, there have been a national measles outbreak, and I think it's important to know that for as much as over the years we've done a lot of we've got a lot of gains when it comes to childhood immunization. We've seen that we need to educate people more so that we don't go back, because the measles outbreak, Carnifing Hospital was in the center stage, so and I think I can speak for that. So what is the status of pediatric vaccine availability in the Gambia, and what do you think we can do, or we can enhance, or we can improve on to be able to avoid such outbreaks in the future?
To start with, I would say pediatric vaccination, EPI, that it's something in the Gambia, which has really improved. And then we as a country have done a lot of things and has achieved a lot of milestones. And that this is not a political statement. So, but we will all agree, before the outbreak, something happened in this country or in the world. The COVID. COVID had created a lot of problems and had crippled a lot of health activities, and one of them was the EPI, immunization for children. And then the minimum immunizations that is recommended for you to be able to prevent a lot of communicable diseases or diseases that can affect children is 80%. But when COVID came, we went down to 69%. Then it's not surprising we had a measles outbreak. So this is something that we should have we should have had expected, and then put some plans, some strategies for, because we were not vaccinating at that time. And then I know, 1st February 2022, that's when the outbreak happened in the Western Health region. And then in a month, about 35 patients were confirmed. This was a major outbreak. What you can see was the reaction that took place was very robust. Otherwise, still now we would have been talking about some of the problems that happened. You see here, immunization in children is routine. In fact, going to what we call NES, it's something that all mothers expect to happen. You don't need to encourage a mother to send a child for immunization or for weighing. So that one, my problem is after discussing with other people who are really engaged in immunization, it's the campaign we have. For example, the papilloma vaccine to prevent cervical cancer. You realize when they go to school to give it to our girls, our girl child in the school, most of the time parents, withdraw consent. Either they wouldn't send their children to school that particular day, or they would not agree for their child to be vaccinated. So I think to solve that problem is just education, and education has to be strategic. You don't have to sit on the radio, on the TV. It's very important. But then you have to engage the people in the country that matters. Here, this country is a religious country. About the percentage, I don't know, but I can tell you, openly, it's more than 95% you have people who are religious, either Christian or Muslim. So now, and then everybody goes to church, go to the mosque. So engage these people, and then when you are able to get these people's acceptance, obviously the community would.
So you say that there are modalities.
Yes.
Educate people. That's true. I agree with that. So I think let's move on. I thank you for that. And tell us about your challenges. I mean, this one I'm sure you've got a lot to say, but let's summarize it, because certainly there are challenges. It's not all nice and glaring. You would have loved to have a pediatric surgical center, and we would all have all loved that too. But what are your challenges in practicing pediatric surgery, in particular general surgery, as far as pediatrics is concerned in the Gambia, and what's the way forward? Briefly, Dr. Jalo.
Yes, of course. If we have to talk about these challenges, yes, it can take us the whole program. Yes, so I would recognize still that a lot of work have been done, and there are a lot of work in progress. So, but not withstanding, still there are a lot of challenges. And some of the challenges are having a theater to operate children, because the children, as we always say, they are not small adults. The way the mechanics work in children is different from adults, completely different. The way the adult lung works, the way the the child's kidneys work, the way the child's GIT works, totally different from adults. And then when you take a baby, you operate the baby in an adult theater, certainly your outcome will not be as you desire. So everything with children has to be done within its own merit. So within its own merit, one big challenge is having a space, a theater dedicated for operating all the children. Then another challenge is human capacity, having the number. But thank God, right now we have what I may call we may call metastatic residents. Since we came, we were able to support some Gambians to go for overseas training. And among them, we have somebody called Dr. Abla. We have Dr. Balde. Dr. Abla is in Accra. Dr. Balde is in Senegal. Then we have Dr. Habib Jallo. You may think it's a fuller community, in Cuba. Then, but there is another person, Gomez, who is in Kenya. So you see, next 4 or 5 years, pediatric surgery in this country will really improve. But before that, my main problem is before that, what do we need to do? So quickly, I think the ministry should work towards getting somebody, 1 or 2 other pediatric surgeons to be added here. My reason is about 43% of the Gambian population are children, are only 18. Now that's about 1 million people. So now, and then universal coverage for health, we are saying you need 1 doctor per 200,000 population in order to be able to achieve universal coverage of health. So now you have 1 pediatric surgeon, 1 million. So quickly, we need to bring the people here. The other challenge is other materials. For example, in the teaching hospital, the hospital is trying very hard to get what we call scopes, because the world is going towards minimally invasive surgery, to have endoscopes and its working elements. The other thing is having the appropriate drugs to battle cancer. I'm happy the director of national cancer in the ministry is here. Now, to have the appropriate drugs, to be able to battle children with cancer in this country. We are losing a lot of children because the drug is not available. And then, as pediatric surgeons, what we do, when the pediatric oncologist sees, then they give the drug, then we would go and operate. And then we send back the patient to the pediatric oncologist. So if the drug is not there, if the drugs are not there, there will be recurrence. So sometimes I tell the pediatric oncologist, you know what, we would try and sort of like pause. You can imagine, and then the number is huge, he knows. So that's another problem. Another thing is you need incubators. I don't think this is very difficult. I think this is not very difficult. For example, a baby in NICU needs to be sent to theater. And how do we send that baby? Is either the mother carry or we carry the baby, I walk through that distance, through that cold, and then the baby will go into hypothermia. That can kill that baby. Then you come after surgery, you need to also transport this baby back to the NICU. You need something to transport the baby. You know, that's why you need a dedicated theater with incubators. And then you come to the ward, the only place where, the only hospital in this country where, in terms of our setup, where pediatric surgery activity should take place, with all due respect to all the other centers, is Edward Francis Small Teaching Hospital, our premier teaching hospital. So I think the ward there must be set an example for other places. You enter those places, you think it's an eyesore, if I should just summarize it that way. So now, so work needs to be done there. Of course, the authorities are doing what they can, and then some work, some work are in progress, but it's good to highlight some of these things. There are good things in the hospital. Right now, the Department of Surgery has got accreditation from the West African College of Surgeons to train residents, to train Gambians to become specialists here. without in their own within the Gambian soil. So this is a very good achievement. And then our hospital has been accredited to do training. And then they also, we have, if you go to Department of Surgery, you have, I can say, there are majority of the surgeons that are Gambians. You go to neuro, it's a Gambian. That's Dr. Java. You go to orthopedic, almost there are 4 consultants, 3 are all Gambians. Dr. Carr, you have Juve, and then you have Dr. Marena. You go to general surgery, the same thing, Dr. Jete. So you see, these are all Gambians. So now, if you look at it, we are really making progress. We are really making, but still, we have a lot of challenges.
Thank you so much. I really agree with you on all that you've said. And I can agree with you even more that, it's not difficult to get incubators. These are important, and as for drugs, well, the issues, the problems goes on and on and on. And a pediatric theater, I fully agree. I really, really, really agree. You need a theater that should cater for these children. Having everything that will be according to their size and weight and all that. So I really agree, and I'm sure the stakeholders in the ministry and the other sectors are listening, and I hope they do. Okay, so why don't we move to Dr. Keba Bojang? He's lucky to only have 2 questions from the moderator. Not because he's a scientist like me, no, but I know he can spend 30 minutes on 1 question. But please, I'm begging you, let's just have you to spend 5 minutes or so. 5 or so, yeah? Dr. Jallo has taken all your time. So we are talking about obesity. Dr. Keba Bojang, we've said, is a scientist, physician scientist, and loves talking about obesity. I don't know why, but he just likes talking about obesity. I'm trying to see who is obese in the room. Fortunately, no. But anyway, so Dr. Bojang, take us through about on the negative health repercussions as far as obesity is concerned. And I know you've done some work for your graduate studies and on the local, that is from local data but I'm not sure whether you've actually recognized and identified the risk factors of obesity in the Gambia. You may have, which I've probably missed, but tell us what the risk factors are, if you have identified them in the Gambia, and how they should be managed, so that we can improve on people's health as far as weight control is concerned. Over to you, Dr. Bota.
Well, thank you very much. Like you said, I have interest in obesity. Actually, my research area is in metabolic syndrome. So metabolic syndrome is the situation when you have hypertension, diabetes, and for the students here, obesity in one individual. So for the medical people, they really understand that. Yes. But what is more important is all these hypertension, diabetes, and abdominal lipid in one individual, we've seen that they are all linked to obesity, the mechanistic link. So that's why I have interest in obesity. But before to go on, I want to contextualize obesity to give the clinical context to, because most of us here, actually, I think what they understand, like student, is the social context, if I can. To so many people, maybe in the Gambia, obesity is like, if somebody has body or obese, is like they're enjoying, they are living a good life. But actually, that's the contrary to what's the situation. So what is obesity, for you to understand and see why it is not good medically? Let me give an analogy to hypertension and diabetes. We all understand that So obesity is like hypertension and diabetes. By that I mean, what is hypertension? Hypertension is when the blood pressure in your system reaches a stage where when nothing is done about it, it's going to cause harm to you. Diabetes is when your blood level, your blood sugar reaches a stage when nothing is done about it. It is going to have effect on you. So blood pressure is good. It's essential for your life. Blood sugar is okay. So fat also is good. But if you have excess fat in your body, or if the content of fat in your body reaches a stage, it has negative effect on your health. That's what we call obesity. In fact, it's been diagnosed or it's been considered as a disease by American Medical Association. So in the Gambia, we have obesity crisis. Unfortunately, that is not yet recognized. Gambia presently is facing what we call, when we talk of diseases, we have the infectious diseases, and we also have NCD. We see a double burden. When it comes to nutrition also, Gambia, we have a double burden of malnutrition. We have the undernutrition, and there is overnutrition. Obesity is overnutrition. So when it comes to the health care status in the Gambia, when it comes to undernutrition, Gambia is making progress in that. Because when you look at things like stunting and wasting, progress is being made. But when it comes to obesity, first of all, it's not even recognized as just as such as a serious problem in the Gambia. Because most of us, like we say, if you have obesity, you are living fine. So to answer the question, first, the obesity is not recognized the way it's supposed to be as a crisis that we are facing. And I think it's important that is done now because obesity has a lot of health implications. So obesity cuts across all the areas of health sector. For example, Dr. Daro talks about maternal health. I'm a man, most of you here are men. You really may not have to see Dr. Jabi. Dr. Jallo deals with pediatrics. None of you maybe are not. But when it comes to obesity, it affects all of us. So what are some of the repercussions? Number one, obesity can make you to have diabetes. In fact, when you look at those with diabetes, most of them actually tend to have obesity. Now there's a term what we call diabesity. This is when people with obesity actually end up having diabetes. So when you look around, most of the people who have obesity, why you should recognize it as a medically important. If you have a big body, big obesity, socially it may look fine on you, but at the end of the day, if nothing is done about it, you come down having diabetes, you may have hypertension, and you may have some other things. So the other thing is obesity. It's been found that it increases all-cause mortality. What this means that if you have obesity, it decreases your life expectancy.
1 minute.
Okay. So if you are big, you are supposed to live for, especially for the student, 50 years. If you are obese, the likelihood is you live less than 50 years. That's why it's very important. And researches have been done locally in the country. For example, the first that was recorded was in 1997. It was done by guys in MRC. At that time, they found the obesity prevalence was 2.3 in the Gambia, when overweight is 8.1. So the latest figure, which was 2016, it's like 9.1. And NANA, National Nutrition Agency, they did some studies 2015, the publication 2015 and 2019. First, they found that I think 25% of all the non-pregnant women are actually obese. That is actually alarming. 24.5%. In 2019, it was 29.5. What is the importance of that? Non-pregnant women, 29%. Most of those people, before they'll go and become pregnant, most of them may go into, they have obesity. And what is the danger to that? If you are obese, Dr. Dado knows. If you are pregnant and you are obese, there are can be a lot of complications for the mother. And of course, for the child. It can lead to, I think, interfetal growth retardation. And microsomia. So those can also have impact on the life of that child in the future, what we call fetal origins of adult diseases. If you are a mother, you are obese, it has effect on your child. That child, when he grows old, may also come down with obesity. Of course, it's a vicious cycle. Okay, time is up.
You want to wrap up? Do you have a wrap up question?
Yes, I think it's okay here because of time.
Thank you very much. Bojang, you see, I know you like talking about obesity. That's why I just left it at 2 questions. So your next question is actually we all know that we import, unfortunately, that we import a lot of food here in the Gambia. So what do you know when it comes to the official the work of this? I know this question should have been dealt by if we had an official here from Food and Safety Quality Assurance, for us to inform us as to whether we do have an official list of acceptable contents in the foods consumed. By this I'm talking about as far as obesity is concerned. I'm sure you could help the Food and Safety Quality Assurance to. Are you concerned about the not knowing what is in the food that we consume? I mean, are there any would you link it to the risk factors of obesity in the Gambia?
Of course, that's a very important question. Now, one of the challenges or one of the things we have in fighting obesity. Obesity is a systems problem, but we are using an individual approach to try to tackle obesity. And this is where food safety and
quality assurance.
Yes, that's where they actually will come in. So the reason why, because usually what we have here when it comes to obesity, there is health education. What you need to do is to do exercise. You have to be mindful the type of food you eat. But that is at individual level. The systems approach, because there are a lot of things that actually are responsible for obesity that are actually beyond an individual. Obesity essentially is caused by 2 main things, genetics and environment. You have to have a genetic predisposition before environment has to act on that. Basically, our genetics remain not much change. But then the most important is what we call obesogenic environment. These are the situations that actually are going to make you easily have access to this high density food, or you'll not be able to exercise. So that's where the system approach comes in. And then for the food safety, their role is very important when it comes to systems approach. Now, what they have to do, of course, the content of the food, what we have in terms of fat is very important. But the other regulatory thing that they should do also is advertisement. I don't know whether they need to control. They should make sure that food that actually will lead to obesity or access to high dense food are not acceptable. For example, but I don't know whether they're still doing in the Gambia. You have people advertising, I think Maggi, they call it Nogos, or even advertisement for Coca-Cola and all those things. These are things that they need to control. It should not be acceptable. Of course, structurally is also very important. If you tell me I should exercise, I need the environment. So controlling obesity is beyond health. So transport department should also come in. Parks need to be provided for people. Of course, obesity also social aspect is there, cultural. We need to disabuse ourselves of this belief that when you are enjoying, you need to put on weight. Okay, time is up.
Yes, so you want to wrap up?
Okay.
Thank you very much, Dr. Bojang. I really appreciate you talking about obesity, because we all know that obesity is actually a risk factor for many of these complications, stroke, heart problems, which includes heart failure, myocardial infarction, atherosclerosis, So really, I think obesity is actually, and we in Africa we always say, oh, it's in our genes, but I mean, so we don't make much effort to actually hit the target. But obesity is a serious problem. I know perhaps it's not as it is in the West, but thank you very much for that. So last, but certainly not the least, we have Dr. Diba Yusufa out in Freetown. Hello, Dr. Diba.
Ame, how are you and everyone else out there?
How are you? Welcome
Good.
to the Gambia, virtually, albeit.
Thank
How
you.
is Bo? Are you in Bo Kenema?
Currently, I am in Kono. Kono
In
is in the
Kono,
eastern
okay.
part. Yeah.
All right, thank you. Can you hear me?
Yes, I can. I'm
Right.
also.
Welcome.
Can you hear me too?
Welcome. I've got two questions. We'll just dig right in because we're running out of time. Thank you for your patience for staying on. So just take us through. There is a significant it's disparity in health equity. This is about the Gambia. And there is a proposed national health insurance the goal is to address disparity, primarily when it distinguishes between government, public servants, state-owned enterprises, employees, and the rest. Do you think this is the right way to go as far as the criteria is concerned?
Thank you, Dr. Jame, and thank you, GCRPS for organizing this. I think this is a very important forum where we can, sit down and discuss and reflect on health issues affecting our motherland. So as you all know, I am in Sierra Leone and I've been here for a couple of years now, helping the government healthcare delivery system. But my mind, today I'm really nostalgic thinking about, home and all that. So to your question, whether the national health insurance scheme it's in the right place to kind of addressing health equities and health disparities. I will say yes. I mean, it will not address all the disparities, but it's a big and significant step in expanding healthcare access in the country. So health equity as a concept in general is the provision of healthcare that is accessible and acceptable. So acceptable in the sense of, being of great quality, and then being provided in a dignified space, which is important. The environment has to be dignified, and then with respect. So these will be the components that will go into a healthcare delivery system that is acceptable. And then it should also be accessible in terms of geographical accessibility, and at the same time financial accessibility. So I think Dr. Tunkara Ba mentioned about the different layers of the healthcare delivery system. She talked about the primary, the basic, which is the secondary, and the tertiary. So for us to talk about health equity, we have to address all the different factors that plays in having people accessing these different facilities and at the same time accepting the services that they provide. So let's talk about the primary care facilities that are in these facilities are in the communities, I guess, right? The primary care facilities will be, the initial care delivery facilities that the people go to. But I mean, we need to talk about their access. I mean, are these community people able to access these facilities? when they need them? Are they within reach? Do they have the financial means to get to these facilities? It's important. And then when they get to these facilities, will they be able to afford the care that is provided in there? I mean, in all the different layers, and will this service be accepted in the way I mentioned? So talking about the health insurance addresses the access financially at these facilities. But it's also very critical. It's very, very, very critical, because you need to be able to provide services that the people can access. So health insurance basically is like making health services easy to access, because you pay in advance for it. You are taxed. There are some different methods, but basically you pay in advance for it, and also the government or your employer pays a part of it. So that makes it easy when you are sick or when you need the care, you can get it without sustaining some financial crisis. But then, to your question, there could be still some disparities, right? Because if you are asked to pay a quota of the service fee, then like example, just to talk about the workforce in the Gambia. I mean, that's a report that I read that talks about only 1/3 of the working age group being employed. So 2/3 of the working age group, according to that report, I think from Gambia participate, 2/3 of the working age group are not employed. They don't have routine financial income. And then plus the non-working age group, which is almost 50% of the population. So, whatever method is used in the insurance scheme has to be in a way that it will not create financial crisis when you tax them for the access to care. Like I can think about some schemes that are very good. Like I can think about the Rwanda scheme. What they do, and which is generally good, is to divide the population, along financial income into 4. So the bottommost quarter are exempted from any co-payment. They don't pay anything, because according to their income, they are the bottom quarter. And then the taxes will be on the 2nd and the 3rd and the 75th percentile. That is the 4th quarter. So basically, the people who earn more are kind of subsidizing will subsidize for the poor, which is which to me is is very good. So I don't know actually, because the insurance as I hear hasn't kicked off yet, but then it should address the poor vulnerable population in a way that they will be able to access care without undue financial hardship. So that is the issue with the health insurance. That is like offering health service at the facility. But then, Dr. Jame, I can tell you that health is determined by so much more than what goes around within the health facilities. So I talked about the factors that influences or that can affect persons' access to the facility itself. I mean, all those things. We have social determinants of health, which is kind of like huge and a lot in the list. So addressing all those social determinants of health, it's really important, including, of course, the National Health Insurance Scheme.
Diba, thank you very much.
There is equitable health delivery system in the Gambia.
Dr. Diba, thank you very much. That was very comprehensive. So can we move on to the next question?
Yeah, sure.
Hello, Dr. Diba, can you hear me?
Yes, I can. Sorry, I was muted.
Yes. So we just want to move on to the last. Yes. So to the last question. And this is how it goes. Is the current system of monitoring and accrediting care facilities by executives who preside over not only public care facilities, but often their outfits concurrently, perhaps detrimental to enhancing equity in healthcare? Please discuss. I'm sure you know what I'm trying to ask. You know, you have people who are supposed to do the monitoring and evaluation of systems, and they are part of that system, and they themselves have interest in it.
Thank you. I think that is like a system or regulation issue, because when you regulate an entity that you have interest in, it becomes a huge conflict. So that is I mean, we can talk a lot about the effects of the conflicts, but then when we talk about the private health facilities, so in the lens of health equity, for us, it's just like the nomenclature, because so this it's like nomenclature in terms of ownership. You have the public health delivery system, and then the private. It's just because they are owned by private individuals, but the services that they provide are for public good. So they provide services that are really necessary, and they are for public good. So definitely having, a strict and transparent regulatory system is important, because otherwise, there are things that could happen, and that could go to the detriment of the people, the public good that they serve, and it will be compromised. So, but then still, let's talk about the access to these facilities. Whether private or public, they're supposed to be accessible to the people. They also and access in terms of the financial requirements to access these facilities. So I think the people that go to the private facilities, they go there because most often there is not much alternative. So these services are needed. Most often these services are really, really needed. So when they are needed, they should be accessible. So I think government creating a platform wherein there is competition, there is in the healthcare space, creating innovation in this private health facilities is great. So the more we have competition in the private health, in the healthcare space in general, the more we have this innovative innovations in the healthcare, and it also benefits the population. So, but while all these are going, this competition and the innovation, government has the mandate to regulate. As you said, government has the mandate to regulate, with fairness and with, transparency, and ensuring that there is no conflict in the system, like in the process. So always safeguarding the interest of the population against undue advantage, and also undue exploitation, whether financial or otherwise. So I will say that it's okay to provide an enabling environment for healthcare delivery, competition, and innovation, such that the people will have choice. They should have choices in their healthcare journey. So I will stop that.